Welcome everyone to our SAEM webinar entitled Breaking Barriers, Integrating Mental Health into the Culture of Medical Training. I'm Kyra Reed. I'm one of the Assistant Program Directors for Emergency Medicine at Indiana University. I'll be one of your co-moderators today along with one of our RAMS members, Stephanie. Stephanie, you want to introduce yourself real quick?
So I'm Stephanie on the bottom right of my screen. M4 at Quinnipiac, applying emergency medicine. And I'm also one of the medical student representatives working on the RAMS board. Thank you for having me.
Thank you. So I'll just I'll just say that as we all know, medical training is rigorous, often leaving trainees to address wellness needs reactively. Today, we'll discuss some proactive strategies for integrating wellness initiatives into medical school and residency operations. We'll learn some strategies to overcome barriers like time constraints, stigma, employment concerns, and share some innovative approaches that embed mental health resources into our routine workflows. By normalizing these interventions, we hopefully can reduce stigma and enhance trainee support. So I'm really excited today for us all to discuss methods for fostering wellness and to hear insights from all of you thought leaders in emergency medicine education and wellness. And that I'm very happy that you all have agreed to serve on this panel. So thank you so much for your time. The way the session will run today is that Stephanie will give a brief overview, and then we'll open up to questions from our panelists. But before we dive into all of that, I'd love for each panelist to introduce themselves, provide your role, title, and we'll just go top, left to right, top to bottom. I've already introduced myself, so we'll start with Brooke next.
Hi, everyone. My name is Brooke Para. I also am at Indiana University, also one of the assistant program directors here for the residency program.
Hi, everybody. My name is Vicki Zoe. I'm one of the assistant program directors up in Burlington at University of Vermont.
Hi, everyone. I'm Gabby. I'm one of the chief residents at Indiana University.
Hi, everyone. Honored to be here. I'm Sadia Akhtar. I'm the Senior Associate Dean for Wellbeing for GME at Mount Sinai's Icahn School of Medicine.
Hi, everybody. I'm Zina Nabhan. I'm an Associate Dean for Graduate Medical Education at Indiana University School of Medicine, and I oversee our wellness programming.
Hello, I'm Katie Pettit. I'm the Vice Chair of Education at Indiana University School of Medicine. I just want to say I'm honored to be a part of this panel. To be honest, all I've done is tell Kyra, keep going, you're doing amazing. And that has been the extent of my involvement, I feel like. So I'm just very happy to be a part of this.
Hi, everybody. I'm Julia Jacobson. I'm a third-year EM resident at NYP Cornell Columbia. Yeah, also really excited to be here. And I will help to moderate the chat for Stephanie while she shares her screen for the Zoom. So if there's anything that anyone wants to ask, like without saying it out loud, and just send it on my way.
Hi, everyone. My name is Christina. I'm a fourth-year medical student applying to EM from FSU. I'm happy to be here and give the medical student perspective with Stephanie.
And I was already able to introduce myself, Stephanie Ballin. So we'll dive into the objectives. So when we first thought about what would be important to discuss in this arena, we wanted to address barriers to engagement that we encounter from our different perspectives. And we're hoping that by the end of this conversation, we can all identify the key barriers for both residents and medical students in engaging in mental health and wellness resources. And then we definitely want to identify implementation barriers to share strategies that we've used to combat these barriers. And that comes from various perspectives, including educational leadership. And then at the end, we want to make sure that everybody is able to identify strategies for interventions that schools and EM residencies can use to improve and promote these resources. So in a 2012 survey, medical students entering 6 different medical schools in the United States took the Maslach burnout inventory, and they actually, compared to what you might expect, had lower depression symptoms or a lower inventory for depression and actually higher quality of life scores. And they were age matched with other non-medical student graduate students. And this might be contrary to what you might have hypothesized, as others have wondered, maybe just those entering medical school might already be predisposed to these issues. Yet by the start of residency, almost 1/2 of senior medical students reported symptoms of burnout. So we really wanted to ask ourselves and look at the literature, what's going on in those 4 years that changes so drastically. And we have links to the resources at the end as well. So these are questions for the trainees right now. So to the trainees and anyone else who wants to engage from a trainee perspective, what barriers exist for trainees in seeking out mental health or wellness resources? And then anything that you have found to eliminate these barriers?
I'm happy to get started on answering this question. So I think a lot of the barriers have to do with like time and stigma are what I'll group things into. I think with trainees specifically, we have really long work hours. Oftentimes we're working during the week, and most mental health services are only available during week, like daytime hours. So that is one huge barrier. I think there's also a big stigma that if you try to seek mental health resources, that's something that you're going to have to report to your future employers. If you seek mental health services, that this is not what I believe, but I think that people have this belief that it might make them seem weak to others or might make them seem like they have something that makes them like a less successful trainee than others. And those are all not true. And so I think ways to combat these barriers are just normalizing mental health resources. One thing that Kyra and IUEM does in particular is we require opt-out counseling for all interns that come through the program. You have an appointment scheduled for you. You're expected to attend that appointment. You have no like clinical duty scheduled during that time during your intern year, and you actually have to make a call in order to cancel it. So that's a barrier to cancel. I think other things are peer support, which is something that we do at IUEM as well. On a biweekly basis, we get the residents to come together and just talk through things that might have been challenging over that time. And I think that provides a safe space for people to kind of be a little bit more introspective and think more about what things might be affecting them that if they didn't take that time, they might not have realized. So I think those are all important things. And I don't know if Juliet, you have any other things that your program has done or any other barriers that you've recognized.
Yeah, I mean, I think that for what I've heard from a lot of people, both like medical students and residents, is like theoretical barriers and less like legitimate barriers, if that makes sense. I think there's like so much fear of if I use the programming that my own residency has, what if the actual hospital who hires me like can see what I say? Which like we all are doctors, like we know that's not allowed. We know how there's like so many HIPAA rules and so many ways that our charts are locked and that nobody randomly from the hiring department or the people who, our bosses could ever look into our charts. So I think that there's a lot of that fear. The truth is, like when I reached out to our mental health services that our GME has, it was so easy and they were so willing. They matched me with somebody right away, and then they were so willing to meet with me on like night hours and random times, knowing how like hard or random an ER schedule is. I think there's a lot of like fear and theoretical barriers, and I think there's less than we actually think. So I think the main thing I try to remind people is that no one is looking into your chart. Like you should feel safe. If you go to the ER and your coworkers are then like looking into your chart, again, like any notes from mental health support is like extra locked. And I don't think that your coworkers would ever be like searching through your chart. And that would only be if they're on your care team at all. It would be heavily audited if somebody on your care team was looking through your chart when you work at a hospital. So yeah, I think we need to remind people that they should feel much safer than they do in seeking out mental health care through their own employer, like their own hospital.
I'll jump in from like a medical student perspective here. My school has this thing where we have like the counseling services, which is psychologists, and then they have like an off-site psychiatrist that has no ties to our school. And it's nice to have that option for exactly what Juliet was saying. A lot of students feel more comfortable going to someone who's like not affiliated with our school, not working within the actual school itself. A lot of the psychologists work with some of like the coursework and things like that. So some students see it as like a conflict of interest. So yeah, it's a good thing that they have those two options for us.
And we worked together, the medical students, we wanted to make sure that we were having a conversation, but especially being medical students and residents, we're a little bit newer to the arena. So we wanted to make sure that our perceptions matched what the literature was saying. And really, like everyone's experience is kind of going right along with what we read in the literature there. So definitely consistent findings. And now we'll switch over to the institutional level.
So for those that are in educational leadership, kind of hearing all of these barriers, whether it's perception or definitely exists, what do you all perceive at the educational level to be barriers? Are they the same as what we've heard from our medical students and residents, or are there different ones that maybe are invisible to our trainees? I'd love to hear your thoughts.
I can go ahead first. So, like I said, I'm at the Icahn School of Medicine at Mount Sinai, New York City. I will say that there are challenges from every aspect, even if you're at a small institution or a big institution or health system. So, just to put things in context, we have around 2,700 residents and fellows, and we have approximately like 8 different sites, many programs in GME. And what we have been very fortunate with is about 7 years ago, we created an Office of Wellbeing and Resilience. And so we actually have a Dean of Wellbeing who works very closely with the Dean of GME. And I'm sort of the glue that helps connect the two offices in my Senior Associate Dean role. What we have really understood is that having access to mental health resources is key to the success for residents and fellows. And so we do have a student training mental health resource. Again, it's free for the trainees and for the medical students. There's telemedicine, thankfully, involved because we have multiple sites. But from a barrier perspective, cost is always something to consider. I will say that we have come a very long way from when it first developed this, or what we call STMH. So I think something that perhaps trainees and students may not be aware of is the cost that it takes for a health system to create an opportunity for trainees and students to have access to mental health.
I'm happy to go next, Kyra. I can share with you what we have done at Indiana University and in terms of access, so we provide mental health services for free for all our residents, all our medical students. And these mental health services, although they are within the School of Medicine, all the data is behind a firewall. They're not part of our electronic medical system. We do not have access to it. Even if your colleagues want to go in, they can go in because it's an independent system. But despite that, we still had worries from our residents and students about, access. I do not want to go despite having opt-out counseling, trying to normalize taking time off during your workday to go see a counselor. Many residents opted not to because they didn't want to burden their colleagues in terms of taking over their work to go, or they did not want to go during the workday. And one of the feedback we received is that they wanted access after hours. Also, they wanted access to multicultural mental health providers. They wanted somebody who shares similar backgrounds. And so then we made Timely Care. We became part of Timely Care, which is a national telehealth vendor. We made that available again for free for our residents and students, so they can also have access to somebody at any time of their choosing, unaffiliated with the school. They also have access through the Employee Assistance Program that puts limit on the amount of sessions they could have, but majority of that cost can be also taken over by their medical insurance. So, at IU School of Medicine, majority of the services can come to you at any time of your choosing, and almost more than 90% of the time it is for free. And most recently, in order to normalize, going to see a doctor, because mental health is health, we just released a podcast featuring very well-known faculty members who were interviewed and shared openly about their experiences with mental health challenges and how much seeking help helped them. And these are individuals, our residents look up to. And it was intentional choosing high-achieving individuals to let them know that it can happen to anybody, no matter what your status is. And, taking care of yourself should be a top priority so you can take care of your patients. So we're fortunate in that way. And I think I'm going to put in the chat the different options we have so you can take it back and advocate for getting access to those services at your institution.
Perfect. Thank you, Zena. I have a couple follow-up questions for those that may be wondering too. It's great that IU has these services for free. Do you have any advice or suggestions on how other programs who may not have that can advocate for coverage for that amount? How did IU go about getting that covered for free?
I think I am a strong believer in data. So we had done a comprehensive well-being survey, the PWAC survey. And in our meetings, we included a question about mental health, and we have collected qualitative data about access and barriers. So that was a very common theme. Our medical students had another survey. They shared their concerns. And so it was very well known in the institution that this was a top priority. When our dean came up with the 2030 strategic plan, one of the pillars for our mission and goals was, attending to the health of Indiana and beyond, including the health, well-being, and health of our residents and students and faculty. And so that became important to our mission. So the school negotiated contract with Timely Care. Initially, it was available for the students. I wasn't part of the conversation, so I can't give you details. But then a year later, it was expanded to the residents and fellows as well. So it was really a combination of efforts. We were able to show need and how impactful that would have been on the wellness of our residents, and the school showed commitment. So I think there has to be commitment. It should not be performative, but it should be actionable. If people say we need access and we need expanded access, if the school and leadership care, they should make that available for them, if not for free, at least at a reduced cost. We were fortunate we were able to make it available for free, but even at reduced cost, it can go a long way.
Just wanted to add, similar to what Zaina was saying, that there are other online platforms. So Mount Sinai also has a contract with a 24/7 mental health service provided to all the trainees and students free of charge. And I think it's just a matter of understanding, what is the need that you have for your particular institution, and then obviously including data, which I think is always very helpful when you're talking to the C-suite about any financial support. Also understanding that there are creative ways that can be done. So within your own Department of Psychiatry or the employment health, assistance program can also be another resource, and pooling resources together can be another suggestion as well if you're at an institution that has multiple sites.
We do have a question in the chat. When rolling out these amazing services, how much education and prep was done to let medical students and residents know about these services? Do you feel that is why some people do not use these services or still believe in the myths?
Thank you for this question. I learned you can create the best program. If people don't know about it, it doesn't go far. And, we also learned that residents, I think maybe students are a little bit better, but residents do not check emails. They are bombarded with emails. So we actually collaborated with the mental health department. We did send an email. We do weekly emails with our residents. So we did send that, but we also work very closely with our house staff forum, which our resident group that disseminate, like we have representatives from each program, they disseminate information and take it back to their programs. We did that. We hosted town halls. We also shared information with the program directors, program coordinators to increase knowledge and awareness about the different programs. And so we did a campaign to share what we have. And, once few people know it, it gets escalated. And thankfully, most people are aware of what we have. And obviously we do, for the incoming residents and fellows, we do a GME orientation, we do an annual orientation, and we have a special session dedicated to mental health services, what we have and why you seek help. And we do initial screening for everybody who comes in for their own goodness, to check yourself, see how you're feeling, and take advantage of the resources we have. Hope this answers the question.
That actually segues very nicely into our next question, which is what strategies specifically normalize and standardize wellness and mental health interventions. And it seems like that is a great answer in and of itself. I don't know if anybody else has any other ideas or experiences in this.
Yeah, I just wanted to add, at Mount Sinai, we actually have multiple campaigns for mental health awareness that happen throughout the year. And one of them did, many of the times that we have incorporated a live panel discussion, similar to what was said earlier, where we have actually representation from different disciplines. So having a medical student, resident, faculty member, postdoc, et cetera, talk about their own personal experience with mental health. And I think if you're a medical student sitting in the audience and you hear another student or trainee here as another resident talk about their difficulties and how they're able to overcome that obstacle by getting the access to the mental health resource that we have within Sinai, I think it goes a long way. We've also had leadership talk openly about their journey to mental health. And I think also the other thing to think about, like normalizing it, it's to really talk about it within the residency program and the classes, and to really talk about having facilitated group discussions, having different forums that we have created for our residents and fellows to really be able to talk about any issues that are going on in the program. The other thing just to mention is that at Mount Sinai, we're very fortunate. We have a GME Wellbeing program, and that basically is a GME Wellbeing Champion program where we have allocated funds for specified faculty in all the residencies and fellowships, where they are basically the point person for trainees to go to within that residency and within that department to say, I'm having trouble, or, you know, for example, talking about like work efficiency or workplace culture. They really focus on those areas. We're very fortunate. We started off with just a handful of champions about 7 years ago, and now we're over 60. And so they meet on a regular basis with myself and other leadership to talk about what's going on in the various programs. And just to go back to the earlier question, like our GME Wellbeing Champions are another resource that we lean on to disseminate information about mental health resources and other activities that we have at Simon.
I about that on this too. I think that one of the things that our program does, and I think that I've heard of some other programs do, is they have once a month at our like weekly conferences, we actually have a standard time for 1 hour where each residency class is separated by their class year and has one of our mental health counselors either in person or in a Zoom chat, just talk and like kind of facilitate discussion. Clearly, obviously, that's like a group situation and not like a one-on-one, but it allows residents early on to interact with people from our mental health department and kind of understand who they are and what they do and, you know, how they can maybe help. And I think it breaks a lot of that stigma. It also allows residents who do feel comfortable opening up about like using mental health resources to open up about it. And then I think it helps break that stigma too. And I think somebody had said it that like all we need is like a few people to use it and word to spread. And I think that helps snowball a little bit. I also think that one of the things they do is it's like a very standard process. You email this one person who's part of our mental health department. They actually meet with you once and then they match you with somebody who they feel like, you know, may get along well with you and make you feel safe and supported. Also, just to help moderate the chat, one question is, can you also tell us what percentage of students use these services, both students and residents? And as a resident, I have no idea. So I'm hoping somebody upper level faculty have an idea.
I can share. So annually, our mental health department, they share with us data on utilization and the type of diagnoses they see or the different categories. So for the medical school, the utilization rate is around 30%. And for the GME trainees, and this is, I'm looking at our 23-24 data that was shared with me not too long ago. So 30% for medical students and 22% among GME trainees. And among GME trainees, the highest rates of utilization for our school is for PGY1s and PGY3s. And for medical students, the utilization rate is highest in the 3rd and 4th year. I hope that helps.
I can also share some IUEM specific data for the opt-outs. So before we started opt-out counseling, we had 3% of our residents, which was one who had ever been involved in any sort of therapy through Department of Mental Health Services. And then after we introduced opt-outs, it went up to 50%. And then when we put it into our orientation month, which is the very beginning of intern year, it went up to 60%. And this last year was 78%, which is our highest yet. So each year it's gone up and up. And I do think it's because, you know, creating that culture, people are aware now, people talk about it, you know, it's part of our normal conversation and verbiage of what we offer and part of our wellness curriculum, which speaks to standardizing as well.
I like that you brought that up because I think that time frame of intern orientation, whether it's 1.5 weeks at your institution or 4 weeks at your institution, is this really key moment where you capture your interns at a time where they're very captive audience members who answer their emails still And at my institution at University of Vermont, we integrate our resources relatively early, introduce our residents to the peer support program and the employee assistance programs that we have. And I think that's a really important time frame because they are sponges ready to absorb things and they jump right in August. And we all know that fall slump is a very vulnerable time for our new residents, and they know the resources ahead of that.
I wanted to jump in also and say, as a student, I think that one of the things that has worked well at my school is that there's different options for like mental health and wellness. So some students don't necessarily want to go to see a psychiatrist. And I helped our wellness committee at my school build a program called the Wellness Ambassador Program, which is essentially students that are interested in wellness and mental health, just kind of promoting, just talking about it. And then we always kind of say, here are the resources and this is what we use and here are the counseling services. So I think it kind of helps break that stigma from like a student perspective.
I just want to bring up one question I got messaged to me, if that's an okay time. One of the things I was asked was, as residents or as faculty, if we're getting questions from medical students looking for like advice, or I'm guessing even if we're asked about what our residency programs have to offer, or if they're not really thinking about this yet. I'll say that a lot of times in residency recruitment at my program, we'll get questions about our wellness initiatives, and we make sure to bring it up. I don't know that it's something people feel comfortable asking about on recruitment, which is a bummer. So it's something that we try to be really open about as like a resource that we have. But the truth is I haven't gotten a lot of questions about that. And I wonder if it is because of the stigma or the fear that if they're applying to the program, they don't want to ask about that, even though we're thrilled about our resources.
I totally agree, Julia. I think many of us on this call do a lot of interviews with prospective medical student applicants, and I 100% agree there's a stigma that if somebody tries to focus too much on their wellness during their interview, they're limited 15, 20 minutes with somebody, that it can come off on the wrong way. And I think it's a great point that I haven't thought about a lot, whether or not we should be the ones initiating those conversations and those precious moments that we have with medical students who are interested in our programs. So
Another strategy that's important that's been implied here, but not really talked about, is just the strategy of persistence. I mean, it sounds like the people that are on this panel that are talking, it sounds like, wow, their institutions have this together. This is amazing, but that did not happen overnight. Like, it takes a lot of time and it takes a lot of persistence, and nothing in medical education seems to happen fast. There's just so many people involved, and then you put that on top of so many preconceived notions that people have and policies and procedures that had been in place for years and years. So for those that are on the call that aren't, from one of these institutions, or you feel like you're very behind, just keep being persistent. Find that person that you can talk to and continue to advocate for, and don't give up, because, obviously Kyra has done amazing things here at IU, but she will tell you it was not easy and it took a lot of time. So you have to be passionate about it and be willing to be persistent and just persistently patient, if that's a thing, to make that happen.
I also just wanted to add, I feel like one thing that we talk about, like normalizing things a lot when it comes to mental health. And I think that as we continue to normalize as programs, like the importance of mental health to prospective applicants and to medical students, the more normalized it will be on interviews to say, hey, what do you do with regards to wellness at your institution? And so that can even start with just like normalizing it and like bringing it up proactively on interview days to open that pathway for applicants to ask, like, hey, you mentioned a little bit about this. Can you tell me more about that wellness intervention that you guys have? Or can you tell me like what happens if you see someone struggling? Like, how do you address that? How can you help that resident in XYZ situation? So just, I think normalizing is the name of the game in this realm.
Oh, that reminds me of a point too that some of us were thinking of. So I've always known that in medical school, we're slightly, even if though we're in the hospitals rotating, we're slightly disconnected from like the hospital like family system. So much as once you get into residency, you're really like integrated in part of the system. And so I know that having friends that are residents or attendings and that I can connect with about issues that are affecting wellness, like it meant so much to me. For example, the other day I was talking to Juliet about current events because not being credentialed at a hospital right now and just watching things occur as a bystander, you feel really disconnected. Even though I'm a medical student, and I'm even in hospitals at times, I'm not really part of a solid unit yet. So just hearing from the experience of someone who is, it meant so much. And so it's wonderful to have someone like her. And I'm sure all of you are probably like that as well, to any medical students reaching out. But the leaders who are making us feel a part of the unit when we're still in medical school, it's so important and really means a lot to us. So thank you.
I think that's a good point, Stephanie, that it touches almost on how creating like a culture already in your like department in medical school that's like supportive and open is probably the most crucial thing for any of these things to work. Like you can offer so many resources, but if people don't feel like they can safely use them and talk to people about them, then it's not going to help. And Stephanie and I had been talking about that, this past week, just about how thankfully, like I do feel super safe with our department, and with current events, they've been super clear on how we're always going to support patients and what we're going to do. And that makes me feel taken care of too. Like when they care about our patients this much, like of course they're going to care about me and be supportive and open about like our mental health resources too. It's a good point, Stephanie.
Yeah, I think it starts with that leadership and role modeling. Katie was saying it's hard to sometimes get things started, but like it can start with you. Just I think Kyra has done a phenomenal job of this. Her voice always rings in my ear of like, we don't have a normal job, what we do isn't normal. And just hearing that over and over again is helpful. Being open about your personal struggles with mental health, however much you want to do that, but just making that a normal thing, and even just normalizing that our job isn't normal, and just saying like, oh yeah, in therapy last week when you're referencing a story, instead of being like, oh yeah, I read an article or I heard something, I feel like normal society wants us to hide the fact that we're going to therapy or doing those other things. And no matter what position you're in as faculty, certainly as a resident, as a medical student, you're a leader to someone, whether that's your fellow students, your fellow residents, to students, to anyone else around. You can be that leader by just starting to openly talk about it and normalize it. And that's exactly what you guys are talking about, is that's what starts to form that culture. And I think that's what the most important thing is, to actually normalize.
Those are all great points. And I'll just add on top of that too, that what I've enjoyed hearing from peer support is the verbiage that we use and teach in peer support echoed in the clinical arena. Like that has brought me so much joy, because it's like you're modeling this behavior in peer support groups by teaching, our resident leaders how to do that. And then our peer support groups are hearing this and then taking it with them, to others who may not be at peer support, but they're hearing it. And now we're changing a culture. Now faculty's hearing it, hearing the residents talk like that. And so it's a ripple effect that's really helpful. And then for some of the more resistant to this idea, I found talking about wellness and mental health as a skill that you develop in parallel with your training has been helpful in breaking some of that stigma and reframing the way that some people think about this. Because they think about, oh, wellness is a whole separate thing, it's a buzzword. But if you're thinking about it as a skill that you're developing in tandem with the things that we are going to see that are not normal, because we just are, like, it's not an if, it is. And this will help you. You're going to be, competent in putting in a central line, just like you're going to be a great clinician having all these skills. None of that really matters if you aren't taking care of yourself. You can't implement those skills that you have. So it's an adjacent skill. And so I like to talk about it like that to maybe change some minds.
I didn't even think about that. How I wonder if, now that I think about it as a resident, I work with so many medical students at the hospital. And when I talk to patients, I'm always like, great, do you have a primary care doctor? Do you have a dentist? And do you have a therapist? As like their 3 standard. Hopefully derm doesn't hate me, but I should probably ask about derm and a skin check too. But I feel like when you like loop it together as like, these are all part of like your, your health hygiene, like mental health, primary care. And now I wonder if by saying that more frequently and being open about it, even in our departments and with patients, if that, causes a ripple effect, like a positive spiral of people feeling, oh yeah, I guess I should have that too.
Yeah. And before we move on to our last big question, I just want to ask the education leaders here, we're talking about big lifts. Like, it takes persistence, it takes people's energy and time, and we don't want to burn out people who are trying to implement anti-burnout, needs and wellness initiatives. How do we incentivize some of these roles or offset some of this time that incurs? Do any educational leaders have thoughts about that, about how they've incorporated these roles to be incentivized or to be, to get time or money or whatever it takes to continue these roles and make them sustainable?
I mean, I can answer in the sense that, again, at Sinai, we are very fortunate. Our GME office is extremely supportive. They pay for many of the well-being curricula that we have established, and they do pay for the majority of the well-being champion stipends that we give. But I just wanted to also mention, I think maybe collaborating with other departments can actually decrease the cost that may be associated with well-being work. So whether you're starting off a particular sort of mental health campaign, or if you're trying to offer some service, maybe joining up with another department and decreasing the amount of, financial burden that will fall onto the emergency department may be an option. I think also like a multidiscipline approach at the GME level is extremely important. I will say we're very fortunate. We've had a lot of other institutions sort of follow our lead, and when I was giving advice to their sort of institutional GME well-being leader, I was telling them to start off as a small program. So maybe have a pilot program of 1 or 2 faculty members in the health system to become like these GME well-being champions, to take that as an example, and to have some data associated with it so that you can see the return on investment, because again, that's what's going to really help you support it in the long run. There are many innovative ways that you can implement well-being at the program, department, and institutional level. And I think getting folks that are like-minded in the same room and getting your key stakeholders at the table can definitely help you establish and brainstorm ideas that can hopefully, defer the cost or the overall cost that would make to that particular initiative.
Awesome. Thank you for that answer. That's really helpful. Data is powerful, as we've talked about, and showing people that, I think it really helps to make your case. So thank you. I wanted to move on now to a question regarding when we're discussing wellness initiatives, diversity, equity, inclusion, and belonging are inseparable consideration. They go hand in hand. What are some important ways that our institutions can address DEIB within the trainee wellness paradigm? Do you guys have thoughts about that?
Yeah, Kyra, I can start with that. So again, we spent a lot of time looking at data, and the reality is, when we look at our wellness data, burnout, belonging, access to opportunity, unfortunately, we found out that our African-American trainees tend to score the lowest in terms of fulfillment, the highest in burnout, and the lowest in terms of belonging and inclusion. And the same thing applies actually to women. They tend to have the highest rates of burnout, and fulfillment, and not equal access to opportunities. And so you can't address well-being without looking at the individual as a whole. So what we have done based on that data is we did focus groups to understand the drivers. And a lot of that had to do with the learning environment. You have to create a learning environment where everybody has an equal opportunity to thrive. And so we looked at what's the learning environment looks like, and we saw that there's a lot of mistreatment, disrespect in the learning environment from nursing staff, other healthcare team members, patients. And so we tried to be intentional about our mistreatment process and how residents can report these types of mistreatment, and not only reporting, but us circling back and closing the loop with them to let them know that, we take these reports seriously. We've done training on different units where we thought, the environment was not conducive to learning, and working with the hospital leadership to come up with policies that protect our trainees and faculty from patients who are being aggressive or disrespectful. And finally, I would add is we had created a lot of groups, affinity groups, where these individuals can have a sense of community, connecting with peers, like-minded peers through social events or programming, highlighting their accomplishments so that to help, increase that sense of belonging. But I think, all institutions should look at the wellness data through that DI lens, because we are the products of our experiences, our identities, and you have to factor that in mind. You can't speak about wellness without taking into consideration the identities and the experiences that we all bring into the workspace.
Yeah, I think that's all a really great point, Zena, to kind of comment more on like the affinity group kind of things. I think that's a unique way to be able to create some belonging. And yeah, that is such a huge part of wellness, like some of the medical students were saying on here, even that not feeling like you're fully in the hospital affects you in your wellness and your training and being able to foster some of that belonging. So here at IU, we started a group that's called Queer EM, where our LGBTQ residents and faculty and allies get to create community together. That was inspired by one of our faculty who regularly kind of hosted dinners for the URIM residents to kind of create that community. One of our residents who graduated last year created a group of like Latinx residents kind of throughout residency programs, and just getting to see the impact that makes on people's wellness, I think is profound, because if you have this unique identity, no one else is going to understand the unique challenges that come along with that in your wellness more than other people in that group. And being able to foster that belonging and that community, I think goes so far. And then that trickles into being actually in the workplace and feeling more of that sense of belonging to and having that camaraderie. The other thing I'll say on this topic too is I thought of it as we were talking about interviewing and recruiting and talking about it, because like in our intro, presentation, and we talk about some of these affinity groups, and I mention Queer EM and I say, and this is near and dear to my heart, and I talk about it. And then when I'm individually talking with applicants, then they'll bring it up. Having a identity in the LGBTQ realm isn't always immediately obvious. And so some people might not always feel comfortable talking about it, or I might not present that way. So then they get to ask more about it. And I think we can use that for the wellness things too. If you're saying at the beginning, yeah, we have wellness stuff and I'm really passionate about it, so be sure to ask me about it in our interview. If that's something you're passionate about or want to know more about, like we were talking about before, I think just opens up that door. And when we're the ones starting the conversation.
As an applicant and now going through interview seasons, I'll say that one of the things that kind of I remember stuck out with some of the programs was when they would talk about conferences that you can attend as a resident. Some of them also included like SNMA, LMSA, different conferences that aren't, SAEM, CORD, ACEP. So it was a unique way to bring it up as a whole. And then it made it more comfortable for me as a part of the Latino community to bring it up during the individual interviews.
I think that goes back to like how the mental health resources and all these like well-being initiatives are like not just about what like support we have in terms of like therapy and peer support, but like all of the other well-being initiatives. Like Christina said, I feel like it shows like what the department and what medical education, GME, and medical schools are like doing otherwise. One of the things that we have, which I'm sure is that a lot of hospitals now, is a lot of support if you are going through IVF, like embryo freezing, all of these things. And I think it's like thankfully becoming something that's so comfortable to be talked about in the medical community. There's a much higher rate of infertility for women in medicine, and being able to like know you have that support. There's a clear way to reach that path. There's other people who are like you who are going through it and can talk to you about it. And there's so many reasons to go through it. There's obviously so many reasons that you may be going through this process, and that those really differ from each other. And maybe you want support from that person. So I think that's another way that like wellness initiatives specifically and like will affect how people feel in general and how comfortable they feel like interacting with the mental health resources that we have down the line.
This has been a great conversation. We have a few minutes left, so I'd like to open it up to anyone who has questions or last thoughts. It could be, a question that you want to pose to the panelists, or if you just have a takeaway that you've learned from today that you're going to bring back to your institution. I'd love to hear that.
It's Stephanie Ballant. I'm just so excited that we were able to do this, especially right now, in so many ways, about to enter the hospital as a future resident and politics going on. So I'm just excited to hear everyone's work and hear about all the things going on in the specialty that we're about to enter. So thank you all for doing this, and thanks for kind of reinvigorating me.
Thanks, Stephanie and Kyra, for organizing. I think this is really powerful, especially in the current political climate and everything that emergency medicine is going through, to be able to advocate for what we need and should have at our own institutions. And I think it's always a great example to hear from what other places are already doing to build new programs by example rather than from the ground up.
Thank you for all the comments in the chat. Yeah, I just want to say thank you all so much. This was a powerhouse panel, and I'm just so thankful that you all took the time to share your wisdom and experiences with others and inspire others. And we've definitely discussed some concrete strategies, which are always can be very challenging. And I agree, like not reinventing the wheel, and utilizing your other advocates that you have in other spaces is super powerful. And so I just appreciate everyone's time and thoughts and, working for change. You all inspire me.